Gallbladder varices due to portal hypertension. Sagittal grayscale ultrasound of the gallbladder, left image demonstrates several hypoechoic, cystic appearing structures within the gallbladder wall, arrows. Color Doppler, right image, confirms the vascular etiology. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital. Neoplastic disease. Adenomatous polyp. Gallbladder carcinoma. Adjacent hepatic tumor. Metastasis rare. Non-shadowing. Mass, in the gallbladder lumen. Tumefactive sludge, mobile. Blood, pus, mobile. Gallbladder polyp, immobile. Gallbladder carcinoma, immobile. Echogenic gallbladder wall. Porcelain gallbladder. Gallbladder full of stones, wall echo shadow sign. Emphysematous cholecystitis. Magnetic resonance cholangiopancreatography, MRCP. Magnetic resonance cholangiopancreatography, MRCP, overview. Cystic duct. CBD. Common hepatic. Magnetic resonance cholangiopancreatography, MRCP, involves specific sequences of an abdominal MRI acquired to image the biliary tree, utilizing heavily T2-weighted sequences that increase the contrast between T2 hyperintense stationary fluid in the biliary tract and the surrounding structures. Sequences with intermediate T2 weighting, T80 to 100 ms, are best suited for visualization of the biliary ductal system and surrounding tissue, in particular to evaluate extraluminal structures. Fast spin echo sequences are most commonly used for MRCP acquisition. Various techniques can be employed to optimize imaging, including breath hold sequences and respiratory triggered sequences. Advantages of MRCP over endoscopic retrograde cholangiopancreatography, ERCP, include: MRCP is non-invasive. It does not require sedation. It has ability to visualize surrounding anatomy. Disadvantages of MRCP compared to ERCP include: MRCP cannot simultaneously diagnose and treat abnormalities. Contrast-enhanced MRCP can also be performed with fat-saturated T1-weighted imaging after injection of gadolinium contrast agents that have biliary excretion, such as gadoxetic acid disodium eovist. These agents shorten T1 relaxation, resulting in T1 hyperintense biliary fluid, but require at least a 20-minute delay prior to imaging to allow time for biliary excretion. Coladaco cysts. Overview and Todani classification of coladaco cysts. CBD, LHD, RHD, CD, CHD. Type 1 coladaco cyst. Fusiform common bile duct dilation. CBD, LHD, RHD, CHD. Type 2 coladaco cyst. Extrahepatic saccular dilation. CBD, LHD, RHD, CHD. Type 3 coladaco cyst. Dilation of intraduodenal bile duct. CBD, LHD, RHD, CHD. Type 4 coladaco cyst. Multiple segments dilated. CBD, LHD, RHD, CHD. Type 5 coladaco cyst. Intrahepatic dilation equals Caroli disease. Most common, approximately 50% of coladaco cysts. Type EVA. Intrond extrahepatic dilation, pictured. Type IVB. Extrahepatic dilation only. GB, CD, GB, CD, GB, CD, GB, CD, GB, CBD, LHD, RHD. Cystic duct. CHD. Normal bile duct anatomy. Sphincter of Oddi. GB equals gallbladder. CHD equals common hepatic duct. CBD equals common bile duct. RHD equals right hepatic duct. LHD equals left hepatic duct. GB. Coladaco cysts represent a heterogeneous group of diseases with a common end pathway of intrahepatic or extrahepatic biliary ductal dilation. The Todani system divides the cysts into types IV based on their number, distribution, and morphology. Most coladaco cysts are diagnosed in childhood, but less commonly may be a new diagnosis for an adult. Clinically, coladaco cysts can present with nonspecific abdominal pain or may be found incidentally. Coladaco cysts are often resected due to increased cholangiocarcinoma risk, which can be as high as 25%. In contrast to biliary hamartomas, coladaco cysts do communicate with the biliary tree. Type 1 coladaco cyst. Type 1 coladaco cyst. ERCP, left image, and thick slab coronal MRCP heavily T2 weighted sequence, right image, shows a fusiform dilation of common bile duct, arrows. A type 1 coladaco cyst, representing fusiform dilation of the common bile duct, is the most common type of extrahepatic cyst. Caroli disease, type 5 coladaco cysts. Caroli disease represents saccular dilation of the intrahepatic bile ducts, which may be segmental or diffuse. Caroli disease may be associated with polycystic kidneys. Caroli syndrome is Caroli disease plus hepatic fibrosis. The central dot sign describes the small branches of the portal vein and hepatic artery bridging the dilated bile ducts, which look like a central dot on contrast-enhanced court. Axial and coronal T2 weighted MRI images demonstrate dilated intrahepatic bile ducts arrows throughout the liver consistent with Caroli disease. The common bile duct red arrow is normal caliber. Bile duct pathology. Cholangiopathy. Cholangiopathy. Sagittal ultrasound left image of the porta hepatis demonstrates common bile duct dilation calipers to 1.1 cm. Transverse scan right image through the region of the head of the pancreas shows an echogenic gallstone within the distal common bile duct arrow. Cholangiopathy is a stone in the common bile duct, generally treated with ERCP. Patients may be asymptomatic, but more often have right upper quadrant pain, nausea, vomiting and cholestatic pattern of LFT abnormalities secondary to obstructed bile outflow. Mrcp syndrome. Mrcp syndrome is inflammation and external compression of the common hepatic duct (CHD) caused by a stone in the adjacent cystic duct. It is essential for the surgeon to know about preoperatively because the CHD may be mistakenly ligated instead of the cystic duct. Additionally, inflammation can cause the gallstone to erode into the CHD and cause a cholecystocoldoccal fistula and biliary obstruction. On ultrasound, a stone is typically impacted in the distal cystic duct and the CHD is dilated. The cystic duct tends to run in parallel with the CHD. Mrcp syndrome. Top left image. Coronal contrast-enhanced CT demonstrates a peripherally calcified gallstone, yellow arrow, at level of the gallbladder neck, causing mass effect on the adjacent common hepatic duct, red arrows. Top right image. Axial T2 weighted MRI shows the gallstone, yellow arrow, within the neck of the gallbladder with adjacent layering sludge. Bottom left image. Coronal Mrcp image better demonstrates the external compression of the common hepatic duct, red arrows, by the gallstone, yellow arrow. Note the resultant moderate intrahepatic biliary ductal dilatation. Pneumobilia. Pneumobilia is air in the biliary tree. It is commonly seen after sphincterotomy or biliary toenteric anastomosis, but rarely may be due to cholecystoenteric fistula or emphysematous cholecystitis. Modality Pneumobilia portal venous gas CT MRI. Branching gas. Seen more centrally. Branching gas. Extends to liver periphery. Ultrasound. Branching echogenic foci with dirty shadowing. Branching echogenic foci with dirty shadowing. Causes. Spiky, spectral Doppler. Waveform. Gas can be difficult to visualize by MRI. Gas is T1 and T2 hypointense and causes blooming, more prominent low signal, on in phase images. Pneumobilia, central. Portal venous gas, peripheral. Biliary ductal dilation. A rule of thumb for assessing the common bile duct (CBD) diameter is to assume that the CBD should be 6 mm or less before age 60, but may still be normal if 1 mm larger per decade after that age. For example, an 8 mm duct in an 80-year-old patient may be considered normal. Some sources, however, suggest very small differences with age. Mean duct diameter of 3.6 mm for 60-year-old patients and 4.0 mm for 85-year-old patients. For the hepatic ducts, greater than 2 mm in size or greater than 40% of the adjacent portal vein diameter is abnormal. The common bile duct is often mildly dilated in patients who have undergone cholecystectomy, usually 10 mm or less. In general, malignancy causes more prominent ductal dilation than benign disease. Bile duct infection and inflammation. Ascending cholangitis. Axial contrast enhanced CT left image demonstrates fat stranding and edema around the common bile duct arrows, which is dilated, with wall thickening and enhancement and contains small amount of intraluminal gas. Patient has a history of sphincterotomy. Subsequent coronal post-contrast T1 weighted MRI, right image also shows common bile duct wall thickening and hyperenhancement. These findings are highly suspicious for cholangitis. Obstruction of the biliary tree, most commonly due to cholangiopathy, may cause ascending cholangitis, which presents with the clinical triad of fever, abdominal pain, and jaundice. Charcot's triad. Imaging may be completely normal, although when abnormal, the key findings are hyperenhancement and thickening of the walls of the bile ducts, often with intraluminal debris and/or cholangiopathy. Primary sclerosing cholangitis (PSC). Primary sclerosing cholangitis ERCP, left image, and thick slab coronal Mrcp heavily T2 weighted sequence, right image, show a beaded, irregular appearance to the intrahepatic bile ducts. Case courtesy Cheryl Sado, MD, Brigham and Women's Hospital. Primary sclerosing cholangitis, PSC, is idiopathic inflammation and destruction of bile ducts. PSC is associated with ulcerative colitis, UC, and to a lesser extent, Crohn's disease, and is more common in males. Most 75% patients with PSC have UC, while only a few 4 to 5% of patients with UC have PSC. Biliary imaging shows a characteristic beaded, irregular appearance of the common bile duct and intrahepatic bile ducts. Primary sclerosing cholangitis, PSC, continued. PSC appearance is similar to that of AIDS Chillangiopathy, although cholangitis in HIV/AIDS patients is more commonly associated with papillary stenosis. Long-term complications of PSC include cirrhosis, often seen with prominent caudate lobe hypertrophy, cholangiocarcinoma, and recurrent biliary infections. Cross-sectional imaging is better at evaluating for these complications compared to ERCP. Primary biliary cirrhosis, PBC. Primary biliary cirrhosis, PBC, is inflammation and destruction of smaller bile ducts. Compared to PSC, PBC usually affects middle-aged women and often presents with pruritus. Similar to PSC, chronic PBC can lead to hepatic cirrhosis, often with prominent caudate lobe hypertrophy. AIDS cholangitis, AIDS Chillangiopathy. Patients with acquired immunodeficiency syndrome are susceptible to biliary infection with cryptosporidium and CMV, which clinically present with right upper quadrant pain, fever, and elevated LFTs. The imaging of AIDS cholangitis appears nearly identical to PSC, with multiple strictures and a beaded appearance of the bile ducts. A distinguishing feature of AIDS cholangitis is papillary stenosis, which is not typically seen in PSC. Recurrent pyogenic cholangitis, Oriental Cholangiopathy. Recurrent pyogenic cholangitis, also known as Oriental Cholangiopathy, is thought to be caused by the parasite Clonorchis sinensis, which leads to pigment stone formation, biliary stasis, and cholangitis. Nutritional deficiency may also play a role. The disease is typically observed in patients from Southeast Asia. Clinically, patients present with recurrent jaundice and fevers. Recurrent pyogenic cholangitis features an imaging triad of 1. Pneumobilia, 2. Lamellated bile duct filling defects, 3. Intrahepatic and extrahepatic bile duct dilation and strictures. Patients with recurrent pyogenic cholangitis have an increased risk of cholangiocarcinoma, biliary neoplasia, biliary cystydonoma, cystadenocarcinoma. Axial left image and coronal T2 weighted right images demonstrate multiseptated T2 hyperintense lesion in segment IV consistent with a biliary cystydonoma. There is also a small adjacent cystic lesion in segment 2 that may be an additional biliary cystydonoma or hepatic cyst. Biliary cystydonoma is a benign cystic neoplasm occurring predominantly in middle-aged women. Biliary cystydonoma may be quite large at presentation and cause nonspecific symptoms such as abdominal pain, nausea, vomiting, and obstructive jaundice. Biliary cystydonoma does not communicate with the biliary system. On imaging, biliary cystydonoma appears as a large, multiloculated, cystic mass. The presence of septations distinguishes cystydonoma from a simple cyst. The septations may mimic an echinococcal cyst. In contrast to hepatic abscess or necrotic metastasis, a thick enhancing wall is not a feature of cystydonoma. Due to risk of malignant degeneration to biliary cystadenocarcinoma occurs in up to 15% of patients. Resection is often pursued. The presence of frank invasion into adjacent liver, a large solid component or thick calcification should raise concern for cystadenocarcinoma. Cholangiocarcinoma. Cholangiocarcinoma is a highly malignant tumor of the biliary ductal epithelium and is the second most common primary hepatic mass. It classically presents with painless jaundice. Most cases of cholangiocarcinoma are sporadic, although key risk factors include chronic biliary disease in the United States and liver fluke infection in the Far East. There are three main subtypes. Mass-forming cholangiocarcinoma, peridictal cholangiocarcinoma, most often at the confluence of the right and left hepatic biliary ducts known as Klatskin tumor. Intraductal cholangiocarcinoma, has variable imaging appearance. Contrast-enhanced CT, T2 weighted MRI, Mrcp MIP image, tumor. Coronal contrast-enhanced CT and T2 weighted MRI show an enhancing, mildly T2 hyperintense tumor arrows at the common hepatic duct bifurcation, resulting in moderate intrahepatic biliary ductal dilatation. Cholangiocarcinoma tends to obstruct bile ducts and lead to intrahepatic ductal dilation and capsular retraction. Eventually, the obstruction may lead to lobar atrophy. Risk factors for development of cholangiocarcinoma include Coladaco cysts, primary sclerosing cholangitis, familial adenomatous polyposis syndrome, Clonorchis sinensis infection, thorium dioxide alpha emitter contrast agent, not used since the 1950s. Thorium dioxide is also associated with angiosarcoma and HCC. Primary gallbladder carcinoma. Coronal T2 weighted left image and post-contrast T1 weighted right image MRI demonstrates an intraluminal enhancing mass within the gallbladder, yellow arrows, and an associated portahepatis mass, red arrows, resulting in severe intra- and extrahepatic biliary ductal dilatation. Pathology upon resection showed gallbladder carcinoma with metastatic pancreaticoduodenal lymph node. Gallbladder cancer is a rare malignancy with a poor prognosis. A typical clinical presentation may include right upper quadrant pain, weight loss, and jaundice. Gallstones and concomitant chronic cholecystitis are typically present. Porcelain gallbladder, a result of chronic cholecystitis, is thought to be a risk factor for gallbladder cancer, although this is controversial. Gallbladder carcinoma most commonly presents as a Scheraus infiltrating mass that invades through the gallbladder wall into the liver. Less commonly, gallbladder carcinoma may appear as a polypoid mass. Very rarely it can present as focal mural thickening. Tumor spread is via direct extension into the liver, although lymphatic and hematogenous metastasis are also common. Prognosis is generally poor, although small polypoid lesions may undergo curative resection. Risk factors for development of gallbladder cancer include gallstones and chronic cholecystitis, porcelain gallbladder, somewhat controversial, primary sclerosing cholangitis, inflammatory bowel disease, ulcerative colitis more frequently than Crohn's disease, adenomatous polyp greater than 10 mm or with multiple risk factors, as described above. Gallbladder metastasis. Metastasis to the gallbladder are uncommon. Hepatocellular carcinoma can spread directly to the gallbladder through the bile ducts. Melanoma can spread hematogenously to the gallbladder mucosa. Pancreas. Normal ductal anatomy. Normally, the main pancreatic duct drains to the major papilla, the ampulla of Vater, through the duct of Wirsung, while the duct of Santorini drains to the minor papilla. The sphincter of Oddi is a circular band of muscle encircling the ampulla of Vater. Duct of Santorini drains to minor papilla. Du rsal m1 pa nc ray tic du court. Common bile duct meets the duct of Wirsung to drain into the major papilla. Duct of Wirsung drains to major papilla. Major papilla ampulla of Vater, minor papilla ventral duct. Mnemonic for normal anatomy. Santorini is superior and drains to small, minor papilla. The following anatomy is always constant, regardless of whether an anomaly is present. 1. The common bile duct always drains to the major papilla where it meets the duct of Wirsung. 2. The dorsal pancreatic duct always drains the pancreatic tail. 3. The duct of Santorini always drains to the minor papilla. Congenital pancreatic anomalies. Pancreas divisum. Pancreas divisum is the most common congenital pancreatic ductal anomaly. It is caused by failure of fusion of the ventral and dorsal pancreatic ducts. The ventral duct Wirsung only drains the ventral portion of the pancreas while the dorsal portion, majority, of the exocrine gland output is drained through the smaller duct of Santorini into the minor papilla. Minor papilla. Santorinisal. Ventral Wirsung duct major papilla. Dorsal and ventral pancreas do not fuse. Common bile duct. Meets the ventral pancreatic duct Wirsung to drain into the major papilla. Crossing duct sign. CBD crosses the dorsal main pancreatic duct as it courses to join the ventral duct. Du rsal m1 pa nc ray tic du court. Pancreas divisum increases the risk for pancreatitis due to the inability of the minor papilla to adequately drain the majority of the pancreatic parenchyma. Treatment is sphincterotomy or stenting. Pancreas divisum continued. The crossing duct sign describes the common bile duct crossing over the main duct to join the duct of Wirsung. Crossing duct sign of pancreas divisum. Thick slab coronal Mrcp heavily T2 weighted sequence shows the common bile duct CBD crossing the main pancreatic duct MPD at the arrow. The CBD courses towards the ventral pancreatic duct VPD to empty into the major papilla. The main dorsal pancreatic duct drains separately into the minor papilla. Case courtesy Cheryl Sado, MD, Brigham and Women's Hospital. Annular pancreas. Annular pancreas is a rare congenital anomaly where a portion of the pancreas encircles the duodenum, secondary to incomplete rotation of the ventral pancreatic bud. Annular pancreas. Axial left image and sagittal right image. Contrast-enhanced CT shows circumferential encircling of the pancreas (panc) around the duodenum (d), which is filled with oral contrast. Case courtesy Cheryl Sado, MD, Brigham and Women's Hospital. In a neonate, it presents with duodenal obstruction and is in the differential for the double bubble sign, discussed further in the Pediatrics chapter. In an adult, annular pancreas can cause pancreatitis, peptic ulcer disease, and duodenal obstruction. Common channel syndrome, Pancreaticobiliary Maljunction. Normally the common bile duct and duct of Wirsung, main pancreatic duct, both drain to the major papilla, where there is usually a thin septum separating these two systems. In common channel syndrome, also known as Pancreaticobiliary Maljunction, this septum is absent, allowing reflux between the two systems. Common channel syndrome may predispose to choladacal webs, Coladaco Cysts, pancreatitis and cholangiocarcinoma. PA Panciens. P and C. D. Pancreatitis. Pancreatitis is inflammation of the pancreas, which may be due to a variety of etiologies that share a final common pathway of premature activation of pancreatic enzymes and resultant autodigestion of pancreatic parenchyma. Pancreatitis may range in severity from mild self-limited disease to necrotizing infection resulting in multi-organ failure and death. Ultrasound role of imaging. Ultrasound is useful in the initial evaluation of clinically suspected acute pancreatitis to evaluate for gallstones, cholangiopathy or biliary obstruction. Ultrasound has limited utility in evaluating complications of pancreatitis such as pancreatic necrosis or parapancreatic fluid collections. CT protocol and role of imaging. Imaging of pancreatitis is ideally performed in the pancreatic phase, late arterial, approximately 40 seconds after contrast injection when the pancreatic parenchyma is maximally enhancing, which is the optimal time to detect subtle areas of decreased enhancement suggestive of necrosis. CT may be helpful when the clinical presentation is equivocal for pancreatitis, a patient is critically ill or worsening over time, to assess for severity, detect complications, and guide treatment. CT imaging is not indicated in patients with clinical diagnosis of mild acute pancreatitis, especially if they are improving. CT imaging may be negative or show a mildly edematous pancreas in these cases. Mr. Protocol and role of imaging. MRI is indicated for evaluation of etiology, i.e., cholangiopathy, edema, necrosis, associated neoplasm, and the pancreatic duct. Different sequences in MRI with Mrcp assess for the following pancreatic abnormalities. Mr. Sequence can evaluate for T2 weighted fat saturation edema and fluid collections, Mrcp biliary tree and pancreatic duct pre-contrast T1 weighteds. P H A O N U C L R D E A B T E C T P H A Acute pancreatitis. Acute pancreatitis on CT and ultrasound. Contrast-enhanced axial CT, left image, demonstrates diffuse pancreatic enlargement and parapancreatic edema. The pancreatic parenchyma enhances uniformly, without evidence for necrosis. Transverse ultrasound, right image, of the head and body of the pancreas shows a diffusely enlarged, heterogeneous pancreas arrows due to pancreatic edema. Ultrasound case courtesy Julie Rittner, MD, Brigham and Women's Hospital, Boston. Acute pancreatitis is most commonly caused by alcohol use or an obstructing gallstone. There are two morphologic subtypes. 1. Interstitial edematous pancreatitis. 2. Necrotizing pancreatitis. Acute pancreatitis can be classified either with the Balthazar grading system or by the CT severity index. Pancreatic and parapancreatic complications of pancreatitis. Less than 4 weeks, greater than 4 weeks. Acute parapancreatic fluid collection. Non-encapsulated fluid collection. Pseudocyst. Encapsulated fluid collection. A pancreatic pseudocyst is a collection of pancreatic enzymes and fluid enclosed by a fibrous wall lacking an epithelial lining. The fibrous wall usually takes about 4 to 6 weeks to mature. Acute necrotic collection. Non-encapsulated collection containing heterogeneous material. Walled-off necrosis. Encapsulated heterogeneous, non-liquefied collection with thick walls. Any of the above collections may be sterile or infected. The presence of gas suggests infection, but the absence of gas does not exclude infection. Extrapancreatic complications. Perihilar renal inflammation, which may lead to venous compression or thrombosis. Bowel involvement, may see ileus or even a fistula, often to the transverse colon or duodenum. Secondary inflammation of adjacent vessels can cause vascular complications. Pseudoaneurysm, due to erosion, most commonly of the splenic artery or gastroduodenal artery, and may result in hemorrhage. Venous thrombosis, most commonly splenic vein thrombosis, which may lead to portal hypertension. Chronic pancreatitis. Abdominal radiograph, left image, and contrast-enhanced axial CT, right image, show numerous coarse calcifications in the pancreas arrows. Chronic pancreatitis, most commonly from long-term alcohol abuse, causes irreversible pancreatic damage. A much less common cause of chronic pancreatitis is pancreas divisum. The classic appearance of chronic pancreatitis is an atrophied gland, with diffuse calcifications in a dilated and beaded distal pancreatic duct. Calcifications in the distribution of the pancreatic duct are pathognomonic for chronic pancreatitis. Splenic artery calcifications are commonly seen in this region and can be mistaken for pancreatic calcifications. Check to see if they follow the course of a vessel. Groove pancreatitis. Groove pancreatitis is an uncommon form of focal pancreatitis located in the groove between the head of the pancreas, duodenum, and common bile duct. Groove pancreatitis usually affects young men who are heavy drinkers. The main differential consideration is adenocarcinoma of the head of the pancreas. Illustration demonstrates inflammation within the groove between the head of the pancreas, duodenum, and common bile duct. The histopathologic hallmark is fibrosis in the pancreaticoduodenal groove. Chronic inflammation of the duodenum can cause duodenal stenosis or cystic change of the duodenal wall. Duodenal thickening and cystic change are often apparent on imaging, with cystic change best appreciated on MRI. Groove pancreatitis. Axial left image and coronal right image contrast-enhanced CT shows fat stranding in the pancreaticoduodenal groove, arrows between the second portion of the duodenum and pancreatic head. Autoimmune pancreatitis. Segmental autoimmune pancreatitis. Contrast-enhanced axial CT left image shows a segmental region of low attenuation enlargement of the pancreatic tail and body, arrows, with loss of the normal ductal architecture. T1 weighted unenhanced